started, sir.
So, good evening, friends. I am Dr. Ramesh, Chief of Critical Care Medicine, Continental Hospital. On behalf of Continental Critical Care team, I welcome you all for this webinar session on fluid therapy part 2. Last time we had discussed about the basics and about the 4D concepts and all. Now, this time we'll be discussing about the role of albumin in critical ill patients and postoperative fluid management. As we all know, albumin is a major plasma protein which is responsible for maintaining the intravascular volume and plasma oncotic pressure also. So, albumin, there are some myths and this one and all, whether we can use albumin when the patient is in severe sepsis, inflammatory state, capillary leak syndrome or not. What is the evidence behind that? And in few conditions, there is very good evidence, very good quality of evidence in especially in cirrhotic patients with spontaneous bacterial peritonitis or large volume paracentesis or hepatorenal syndrome and all. In few conditions, the moderate quality of evidence is there. And in cases of traumatic brain injury, we should not use as per the SAFE study. So overall, let us know from our expert panel, like how, where, in what conditions we can use albumin and all. And coming to the postoperative fluid management, which fluid we have to use in which operative cases, like in liver transplantation, kidney transplantation, cardiac surgery patient, neurosurgery patients, which is a fluid of choice in those cases, and how much volume to be used, like what are the factors we have to consider before prescribing the volume of resuscitation, volume of fluid for a postoperative patient, like third space loss, maintenance fluid, how to calculate the maintenance fluid, third space loss, how many hours of fasting did the patient had, and how much volume of fluid was infused in the intraoperative period, and how much was the blood loss. All these factors we have to consider. So to know more about these aspects and let us clear all these doubts with our experts, I welcome Dr. Prashanth Nasa and Dr. ANIRBAN Home Choudhury, who are our expert panelists and who are the authors of rational use of intravenous fluid therapy in critically ill patients. The book what we had. Welcome you, sir.
Thanks, Ramesh. If
And,
I hope you could hear me and you could see my presentation now.
Yeah, I can see the presentation, sir. So first
Okay.
we'll be starting with the role of albumin in critically ill patient by Dr. Prashanth Nasa. Sir is affiliated to Anesthesia and Critical Care Unit, New Cross Hospital, Royal Wolverhampton Trust, NHS Trust UK. He has a vast experience of 17 years and he has published around 100 journals in peer-reviewed articles and 40 chapters in various critical care books. He was awarded as Excellence in Healthcare Research in UAE in 2023 to 24. Areas of interest are AIDS, mechanical ventilation, fluid stewardship, and sepsis. Our second presentation will be by Dr. ANIRBAN Home Choudhury. So about the postoperative fluid management. He's an active member and actively participating in various events of ISCCM. Sir is a director, professor, and HOD of critical care medicine, critical care department in Safdarjung Hospital, New Delhi. Areas of interest including mechanical ventilation, sepsis, nutrition, and ethics. Sir has received various honors and awards also, like Sarvapalli Radhakrishnan Distinguished Professor Award in 2021, Presidential Citation ISCCM, Award of Excellence from ISA 2018, Delhi Pradesh Bhagirath Samman in 2014. Sir has published around 92 publications and journals and 36 chapters he has written, one patent and 2 books he has written. So followed by our question and answer session. I request all of you to write down the questions in the chat box so that we can ask the speaker and clarify our doubts. Without wasting much time, over to you, Prashanth. We'll start with the first session.
Thanks, Ramesh. Thanks for the invitation and thanks for having me here. So without any delay, I will start because I see even Manu has joined. So we'll start with the first one, which is albumin in critical care. Of course, that's my conflict of interest and that's my area of interest also. We recently published early this year this book on rational use of IV fluids in critically ill patients. And on my last check, it has already been downloaded by more than 1.2 million people. I will be hopefully sharing the link, or even Ramesh must have already done that. So it's freely available and have been well received, and probably their different names have been given, blue book or IV fluid book. So please, if you want to access it, it's an open access book. We'll start with a common case scenario, a hypothetical case scenario. A 52-year-old male patient admitted with pneumonia and septic shock. He was resuscitated already with a significant amount of balanced crystalloid as a part of IV fluid resuscitation. Still, patient is hypotensive and fluid responsive on a couple of vasopressors, norepinephrine, vasopressin, and still mean arterial pressure of less than 60. What will you do? Continue to resuscitate with the balanced crystalloids, or use increasing the dose of vasopressors, consider colloids, or maybe hydrocortisone, and or if you would just want to wait and watch. So these are the common scenarios which we usually see in our bedside practice on a daily basis when we have given large amount of fluids, especially, and we are not sure which way we are heading. Despite that, patient remain hypotensive, a common scenario with profound sepsis and septic shock. And this is the reason we actually started asking people, while the people who were attending IFAD meetings from 22 to 22, and also through our social media channels, this large cross-sectional survey, which was done in nearly 97 countries, and more than 1,000 participants participated in this survey. When we asked them, how do you know IV fluids? Are you comfortable prescribing IV fluids? Usual scenario was most of them were comfortable. We believe we are, expert, like this person who had this silver medal won up in the recent held Athens Olympics. And that's what we believe, because IV fluid was given to us as one of the first drug probably, and we have been prescribing them starting from our medical school. As soon as we finished our medical school, this has become part of our daily job to prescribe different IV fluids. But the reality is, when we ask participants, and these were not simple participants, these were all people who are practicing in intensive care unit where IV fluid constitute a major drug as a major prescription thing, which they have to do it on a daily basis. And if you see the average passing percentage with the average number, average score for this group was only 46.4%. So they have not even passed the exam. And that what is the reality. So in the same, cross-sectional survey, when we asked them, how do you use 4% albumin? Uh, Nearly half of them are using them for patient with sepsis. I believe this situation has not changed despite the survey is now nearly more than 2 year old. Situation is even in fact probably increased, and I will be sharing very recent published article which actually looked upon the further use of albumin, how is it being used even in high income countries. So albumin, besides the sepsis, when we asked them for 20% albumin, beside the sepsis, there were around 60% of the participants who said they are using albumin for deresuscitation. And that was another major indication for use of albumin. Commonly, we prescribe that not just part of the resuscitation, but also part of deresuscitation. So I will be talking on both the aspects, when and where, and what is the evidence to support or to say we should be very careful of using albumin. So we know that albumin is a very commonly, or it's one of the major constituent of the human plasma. It's a predominant form of protein which we have in intravascular compartment, which regulate our colloidal osmotic pressure, helps in binding various drugs and hormones. As antioxidant properties also have a very, very important role, which have been now established in the part of endothelial glycocalyx. So it constitutes an important part of the endothelial glycocalyx, besides its other function, which involves the buffering. And we also know that hypoalbuminemia in patients who are critically ill adds to higher risk of morbidity, adds to their increased length of hospital stay, and definitely there is even higher risk of mortality. So hypoalbuminemia is bad, we know that, and albumin is an important constituent. But whether replacing albumin does change the outcome, and that is the question, that is a $1 million question I will try to answer probably with this talk. So I will put albumin into these 4 phases as what we should be doing the use of IV fluid like a drug should be built up around these four things, which has been proposed a few years back by Professor Malbrain as a ROSE concept, from resuscitation to deresuscitation or evacuation. So how and where we can use albumin and whether we are using it appropriately or not. So let's start with the resuscitation. And we know that hypovolemia is bad. It adds to the multi-organ failure, but definitely hypovolemia is bad. And that is the big concern which we have understood in last decade, that it's not always required to resuscitate with larger volume of fluids. We need to consider, vasopressors to reduce the amount of cumulative fluid balance, because we know that hypovolemia itself leads to morbidity and mortality. And it's not just the hypovolemia. Any overfluid resuscitation also leads to worse outcome in our critically ill patients. And the same thing is, we know that there is a leaky capillaries, especially in certain diseases like sepsis, or even patients who are coming out of anesthesia, where glycocalyx has been proposed as a major reason, one of the major important component which decides the amount of leaky capillaries, and it gets disrupted into any disease state, especially sepsis. And being albumin a very important constituent, we believe that by giving albumin, we are trying to plug up these holes to reduce, the leakage of the fluids, and that what has been proposed as a major reason of use of albumin in the resuscitation, besides its use of as volume expansion, which we know. So the evidence have tried to answer these questions, not very clearly, but yes, there have been studies which have looked upon use of albumin, especially for the resuscitation. We know the SAFE study, which was one of the first study which in fact did not show benefit of albumin, but at least showed that albumin is safe as like any other resuscitation fluid. But to mind you, this was being compared with the saline bag, not just balanced crystalloid. So this was one of the earliest study which was looked upon, or at least looked upon the safety of use of albumin in the resuscitation, which demonstrated that there is no difference in outcome for using albumin versus a saline in resuscitation. And then in the subgroup analysis, in fact, in patient with sepsis, they found a mortality benefit when they did a subgroup analysis of the SAFE study using albumin. Followed by this LBOS trial, which actually used albumin within first 28 days of randomization. So it was not every time, we were doing resuscitation in this cohort of patient. In fact, the target was to achieve albumin above 3 gram percent rather than to do a proper resuscitation with a macro perfusion target. So it was to target albumin above 3 gram, which was the main endpoint for this study. And there was no difference in 28-day mortality when they tried to target albumin above 3 gram percent in the intervention group. Then in patients with septic shock, again, in the subgroup of patients with septic shock, they found a lower day 90 mortality in the same cohort, followed by this study, which was never published but presented as part of abstract into Lives 2011, the ESICM Lives 2011 conference. A French study involving 29 French ICUs, again a randomized study where they used 20% albumin instead of the 4% albumin as used in the SAFE study, where the albumin was used for the first 3 days versus a saline. Again, there was no difference in mortality, though the patient with albumin had a lower rate of vasopressor requirements as compared to the patients who were given crystalloids or saline. Relatively recent study, which was done in, again, a single-centric study done in Brazil, comparing 4% albumin versus ringer lactate, probably one of the only study which has compared albumin with at least a balanced crystalloid or ringer lactate. There was no difference in mortality between the two study groups. And again, going back to, moving out of sepsis to a subset of population like patient with cirrhosis. So patient with cirrhosis, when they have sepsis-induced hypotension, so these two single-centric studies which were done both from India, they looked upon the use of albumin versus a saline for resuscitation of patient with sepsis-induced hypotension in patient with cirrhosis, and they found a lower mortality in the first study, where they found lower, a better survival of 7 days and a lower mortality and better improvement in hemodynamics and tissue perfusion. Again, they did a comparison with 20% albumin versus plasma light. So previous study was with saline, and then they repeated this study with plasma light. They found there was no difference in survival, but definitely there was faster improvement in hemodynamic and lactate clearance with the use of 20% albumin as compared to the plasma light. So at least subset of patient with cirrhosis and sepsis-induced hypotension, these two small randomized control trials showed some benefit, both when they were compared with saline or they were compared with plasma light. And then we have this, understanding whether 4% is better or 20% is better for resuscitation. So this particular study, which was done from Australia and UK, they did comparison of, they did a resuscitation with both 20% albumin versus 4.54 or 5% albumin, and targeting serum albumin above 3 gram per deciliter, where they try to look at again the outcome. There was no difference in mortality, but the patient with 20% albumin required lower volume of fluid for resuscitation. The positive or the cumulative fluid balance was less positive in patients with 20% albumin at 48 hours as compared to 4 to 5% albumin. So at least the other benefit where we wanted to restrict the amount of fluid, so their 20% albumin scored better in terms of decreasing the volume of resuscitation and also to reduce the volume of positive cumulative fluid balance after 48 hours of resuscitation. Now coming back to the FEE study, which is something which was a major reason we understand that resuscitation is not something which is always giving a lot of fluids, 30 ml per kg, which hit back to our thinking of giving large amount of fluid for resuscitation. The study which was looked upon use of fluid boluses in sick patients, sick children in Africa, where the most of the children were having sepsis because of tropical disease like malaria, and the mortality was higher with giving fluid boluses as compared to not giving fluid boluses. So when they did a reanalysis of the FEE study, they found that it was not just the fluid boluses, it was not just the fluid amount, but also the fluid boluses which was causing damage, probably because of endothelial disruption, which happens, which we understand now happens with more fluid boluses as compared to relatively targeted infusions. And the partial sort of morbidity and mortality in those patients was also contributed to because of hemodilution and hypochloremic acidosis, with reducing hemoglobin concentration because of hemodilution. So that was partially responsible for the poor outcomes by using fluid boluses in these patients. And that also tells you that resuscitation should be precision based and should be personalized rather than should be empirical as recommended by most of the guidelines. We know this among the colloids, the starches are almost dead because of these large 3 randomized controlled trials. And now we among the colloids, if we have to use, it's the predominant, which is albumin, which is left to us. Other than at certain places it's still gelatin, which has its own problems, which is out of scope of this presentation. But yes, among the colloids is the albumin, and we initially believed that albumin has a ratio of 1:3, which was actually proven wrong. In the SAFE study, the volume expansion, which was, the ratio of volume expansion was 1:1.4 or 1:1.2, not 1:3 traditionally, which was thought. And also we thought that like hetastarches, albumin may, especially being an hyperoncotic 20% albumin, may lead to increased incidence of AKI. At least these small studies did not find LBOS studies, or even the patients with cardiac surgery, they did not find any increased incidence of AKI with the 20% albumin if given within the the constraints of the volume. So they did not find any increased incidence of AKI in these patients, unlike what we know with starches, which is a big problem, and that's the reason for their discontinuation from the market. So then, these all trials were actually put forward for meta-analysis, and that's the way most of the guidelines, come up with research or an evidence-based recommendation. And when they put up these papers into meta-analysis, at least they found there is some sort of benefit in terms of patient with sepsis and septic shock, that albumin administration leads to lower mortality, and that led to recommendation by surviving sepsis guideline, where as first recommendation was to use 30 ml per kilogram of IV crystalloid, which is of course one of the controversial statement which has been debated many times in most of the subsequent papers, and is still an ongoing debate whether 30 ml per kg is really required for everyone. But other than that, they also recommended to use albumin as in patients with large volume of crystalloid. So the recommendation was to use albumin in patients who have received large volume of crystalloids and who continue to have sepsis induced hypotension. But and that led to so-called recovery of albumin as one of the major resuscitation fluid, along with the balanced crystalloid, which came as a recommendation. And if you that what I said very recently, this article which was published in CCM, looking at a single centric use of albumin in their critically ill patients, in nearly 8 years of their ICU admissions, they looked at 21,000 patients, in which 3,700 patients were given albumin, and 2,000, nearly 2,000 patients actually were given fluid as an albumin for IV resuscitation. And what they found was there is a trend of increased dose of albumin, partially because we are no longer having any more starches, which has been removed from the market, but also because we have been proposing this as part of the guideline that albumin can be considered after a large volume of crystalloid as a part of resuscitation. What they found was the use of albumin, sorry for the busy slide, but yes, what they found was that use of albumin has increased considerably in patients with septic shock. So nearly in their center, the use was doubled, and that's what we found in our cross-sectional survey. Also, nearly 50% of the participants agreed to use albumin for resuscitation, and another 20% said it for other phases. But yes, as part of resuscitation, they found septic shock as one of the common indication where the use has increased, besides the patient with renal failure and even patients with hypoalbuminemia. So still people are trying to target hypoalbuminemia as one of the resuscitation endpoint, as what was done in LBO study, despite showing no benefit. So this study actually found that the use has increased of albumin by nearly 6 times, from 5% in 2013 to 33% in 2021. What was another important thing was they tried to look at whether hemoglobin in terms of volume expansion by looking at drop in hemoglobin without any actual overt bleeding. So they looked at volume expansion by looking at the hemodilution, and they found the hemodilution, or so-called volume expansion of albumin, stays up to 12 hours. And that what we also believe that it stays into the intravascular compartment much higher as compared to the balanced crystalloid, and that is one of the reason albumin is considered as a good volume expander, especially when you are having a leaky capillaries. And there they proposed that actually this was causing more transfusion requirements because it was hitting the target of less than 8 grams, where we start to give transfusion thinking, especially in patient with septic shock. So in their scenario, it was causing volume expansion but causing hemodilution, and they were giving unnecessary more transfusion in these patients. And that is something which they propose this need to be considered, whether we really need transfusion in these patients, because there were no signs of bleeding, but it was all effect of the albumin which was causing hemodilution. And very recently, the guidelines again looked upon the evidence of using albumin in resuscitation, and they came with a revised meta-analysis where they proposed albumin is actually not better than any of the balanced crystalloid, or in fact there is a signal of harm in patient with traumatic brain injury. There is a very small signal of benefit in patient with septic shock, but other than that, there is no very clear evidence to support use of albumin as a resuscitation in most of the critically ill patient. In fact, in patient with traumatic brain injury, one should be very careful because of higher risk of mortality, at least that was shown in the SAFE study, that in patient with traumatic brain injury, albumin should be definitely avoided. So the recommendation was changed from surviving sepsis guideline to this ESICM 24 guideline on use of IV fluid, where they suggested use of crystalloids rather than albumin for volume expansion in adult critically ill patient. And if we are using albumin, still there are a lot of open-ended questions which we don't know which formulation to be used, how much to use, and at what level of crystalloid we should switch to albumin, what volume we should be using, and whether we should target any particular albumin level, or it's okay to look at your macrodynamics and macrohemodynamics or macroperfusion targets rather than looking at albumin levels as what was looked in LBO study. So these are open-ended questions and we still need more answers. Without these answers, I think the evidence which is there is really bleak and doesn't support use of albumin resuscitation, at least. Coming to the other two phases which are important, coming to the stabilization, and here I think there is a bit of observational studies which have looked upon at least combination of PEEP, albumin, and diuretic like a Lasix or a furosemide, where they found that using these three in combination, where PEEP is set equivalent to intra-abdominal pressure and albumin 20% used to bring out the intravascular fluid to intra-alveolar fluid to interstitial and interstitium to intracapillary, so that whatever the leaky capillaries have produced that intra-alveolar fluid, that is coming out of intra-alveolar fluid. By giving this combination, they found that patients were having a negative fluid balance. They could produce lower extravascular lung water and improvement in both intra-abdominal pressure and clinical outcomes. At least this observational studies showed a benefit in terms of improvement in oxygenation and improvement in or lowering the extravascular lung water. And then followed by, there are 3 RCTs which was clubbed together for this systematic review, which was recently published, where they looked upon in patients with mechanically ventilated patients with hypoalbuminemia, whether there is any benefit of giving albumin. And what they found was, at least in so-called, other than mortality, that there was a benefit in terms of improvement in hemodynamics, reducing the number of mechanical ventilation days, and improvement in the PF ratio. But the evidence is still very low to moderate quality, and they actually concluded that further research is required in this area because the evidence is with very small single-centric studies, and one cannot conclude for sure that definitely the benefit was being happening because of albumin alone or these combination of PEEP and along with diuretics. So yes, in patients with ARDS and mechanical ventilated patient with stabilization, where you have tried other therapies and you are trying other therapies, this could be a combination along with diuretic and PEEP. One can be considered, especially in patients who are hypoalbuminemic. Coming to the deresuscitation part, I think uh, an ongoing heated debate and an ongoing research which is there for deresuscitation, where albumin can be used or should be considered along with diuretic, because we know that patients do not always go into flow phase. There are patients who will continue to retain water and they have a cumulative fluid balance. So these are the patients which develop so-called global increased permeability syndrome, and that is not something which is benign. That leads to a multi-organ failure state, involves almost every compartment or every organ of the body, and these patients definitely need some sort of evacuation of the fluid. And there are different modalities which have been looked upon to look at removal of fluid in these patients, and I will highly recommend a very nice open access article by Professor Malbrain on deresuscitation if you are more interested to know about it. But in deresuscitation, there is a definitive role of diuretics. Whether we need to add albumin is something still been seen in smaller observational studies, where they found that at least in patients which are hypoalbuminemic and diuretic is resistant to reduce that fluid balance or is unable to help you out in the evacuation phase. So combination of diuretics with albumin leads to better urine output and able to reduce the cumulative fluid balance and helps to deresuscitate these patients. Though the evidence is still very small and needs large randomized controlled trials to look on this aspect. And we also know that fluid restriction is not every time benefit in every patient, because the trials which have looked on fluid restriction did not show any major benefit. But yes, this is an ongoing thing which need to be further researched. So study could not, and this particular study looked upon again using albumin along with diuretic, where they found that very low albumin contributes to diuretic resistance. So in patient with where you are considering a diuretic resistance, and especially patients who are hypoalbuminemic, giving albumin along with diuretic may help you if you are not having a immediate support to renal replacement therapy. But in case if this fails, then definitely renal replacement therapy is one thing which can be considered. I did not go into detail of patients with cirrhosis, where there is definitive at least two indication, but this very recent guideline which was published in 24 again touch on two other areas where albumin is still being used and considered, and they reviewed the evidence where they looked at use of albumin to reduce intradialytic hypotension, and then they did a meta-analysis. The benefit is still not there to show that albumin can be used safely or can be used with benefit to reduce intradialytic hypotension. Again, a very common way of using albumin or misusing albumin. The other thing is to use albumin as priming the cardiopulmonary bypass circuits. Again, in certain centers, they are very fond of using albumin as the priming volume. There is no benefit in terms of any major improvements in outcomes, whether hemodynamics or in terms of mortality, which was found in this guideline. Now, as I said, I did not go into depth. These are the two still most common indication which they proposed with a fair amount of evidence, that in patient with cirrhosis, which are going with large volume paracentesis, which means removal of fluid, removal of ascitic fluid more than 5 liter. To prevent circulatory collapse, you can consider giving albumin, and definitely the evidence is supportive over there to prevent circulatory collapse or to prevent hypotension after large volume paracentesis. Albumin is definitely has a role, and definitely in terms of patient with spontaneous bacterial peritonitis to reduce mortality, there is an evidence. But in patient with cirrhosis, where there is an extraperitoneal cause of infection, other than resuscitation, there is no evidence that use of albumin reduces AKI or improves outcome in these patients. So evidence is only for SBP, not for other sources of infection in patient with cirrhosis. So putting back everything what we discussed, definitely the role of albumin in resuscitation is very, very controversial, and I think it's only to be used in very selected group of patient where you have considered all other options and patient still remain hypotensive, because the evidence doesn't support, and even the recent guideline says crystalloid should be used over albumin for resuscitation. For deresuscitation, there is evidence which is there, but coming from mainly observational studies. So on case to case basis, I think you should consider use of albumin rather than use it empirically. We know that it is coming from human plasma, which is, so it has the same side effects or effects as like any other human blood product. And also there is a cost which is attached to a use of albumin, which is fairly high, especially in the resource limited setting. So be very, very mindful of using albumin even in those settings. And but on case to case basis, this could be something which is still to be considered, at least in the stabilization or in the deresuscitation phase. So I think albumin is one drug which is moving from so-called evidence-based medicine to precision medicine, because none of the trials other than patient with cirrhosis and with SBP or LBP, the evidence is not supportive of use of albumin in most of the patients, and it has to be used more on a precision-based or on an individualized basis. And I will leave that this last slide where albumin should be treated as like any other IV fluid, as like a drug, and it's in search for a right patient, probably a right indication too. Thank you.
Thank you, sir. It was an excellent presentation on albumin and in various diseases and various specific conditions also with evidence. Next, we will let us move on to our next session on postoperative fluid management by Dr. ANIRBAN Home Choudhury.
There was one question in the box
Yeah.
about the use of 10% albumin. Prashanth, would you like to answer to
I've
that?
never seen 10% albumin, Professor Melvin. Have you seen?
There was a question. So I remember that in 1988, an article was published in Intensive Care Medicine, where the author Krutensberg or something, I can't remember, said that it is the most abused and expensive drug in critical care. And in 22, this one, it is the slide you showed, the 10 myths about albumin. So it's all like traveling the circle. So no displacement and work done is zero. So that's a very sad story, but still I think that there is role of albumin in a lot of specific situations pertaining to the liver failure patients, and few more. Routine correction may not be advisable. So,
Welcome, Professor Malbrain. Welcome, sir.
Welcome, Dr. Malbrain. Good to see you.
Regarding 10% albumin, sir, we usually use in post-liver transplantation patient to replace the drain. If the drain is around 1000 ml, 25% of the replacement of the drain fluid after second day, third day, like that we use. You ask me whether it is evidence-based or not, not much of evidence.
Seems more of a local guideline base, but why
But it is
10%? Why not
available.
20% albumin? Is there any specific
Because
reason and why it's available only 10%?
yeah, in few articles of post-liver transplantation management, it is specifically mentioned like 10% albumin, 25% of the total drain loss. That's like in few guidelines we read that one. So based on that, we are using that.
Okay.
Any comments, Professor Malbrain, sir?
Well, maybe we could discuss a little bit if you're. I believe in albumin 20%, and for the deresuscitation phase, I think there are some kinetic studies showing that it indeed helps to mobilize the interstitial fluids in case of pulmonary edema. The question is on how much do you give, and do we give it in a bolus or a continuous infusion? What about the impact of albumin on glycocalyx preservation? So I think there's a lot that we don't know yet, and as you nicely pointed out, going for personalized, individualized medicine, there may be cases where it should have a place.
So we'll take the next questions at the end of the session. We'll move on to our next session, post-operative fluid management by Dr. Anand.
I can go, but since Prashanth had already told
Okay.
beforehand that he has to take his questions.
So
I request if anyone has any question, they can
please.
post right now. And
Regarding Barnes patient, Prashant sir, like there is some large meta-analysis on Barnes, use of albumin in Barnes. What is your opinion on that? They have shown that some AIDS chances are more in that.
Yeah, I think again one area where traditionally or by myths people were using albumin, but the evidence is not supportive. So as Professor Manu said, in resuscitation the evidence is not supportive, and in fact there is signal of harm in certain subgroup of patients, as you said, in patient with burn and in patient with traumatic brain injury. So you need to be very careful. But yes, in a later phase of the patient stay, especially where you are considering deresuscitation or stabilization in certain subset of patient, I think albumin, especially the 20% albumin, has role. But also somehow we don't have enough studies to back this up. We need more studies to look on this aspect of patient. Probably in future we will have these subset of patients which are studied more for deresuscitation and use of albumin in that subgroup of patients.
Yeah. And in post-intestinal resection and anastomosis of the intestine,
Surgeon favorite
prefer
question.
albumin in the in the post-operative phase so that the anastomotic leak and intestinal edema will come down. That's what.
That what this half-life of albumin which we replaced exogenously is not more than 8 to 10 hours versus what we believe is endogenous albumin which stays for 120 days. So it's whatever you are giving, unless you are not replacing enough nutrition and all, I don't think that is contributing to anything. It's only being used as any other IV fluid. So, and it's definitely does not replace your maintenance requirements. So albumin in those scenarios, to build up albumin intravascularly does not do anything, and there is no evidence to support that giving external albumin improves outcome in those patients. And then it's a costly exercise to do that.
Unless you're a surgeon.
Unless you are a surgeon, of course.
Since our topic is post-operative fluid management, um, so apart from that, in capillary leak syndromes with various viral infections or some bacterial infections and all, do you recommend like as after the septic shock with the crystallized resuscitation, do you recommend albumin or should we avoid it?
Again, the evidence is lacking, but yes, this is something which is good research, probably should be considered in India. For at present I am not aware of any research in tropical fevers, especially like dengue shock syndrome, where albumin has been used along with resuscitation. Most of the research for albumin resuscitation has been done in traditional sources of sepsis, and we know that in patient who were having malaria, at least the FRIC trial showed us that albumin was equally harmful as like saline in those patients. So we need to be careful. We don't know whether it works differently into certain other viral illnesses with predominant capillary leak syndrome. I think without study, it's too empiric, and rather than it's more practice based to say to recommend that one should consider use of albumin, because we know whatever we give, they leak. And dengue shock syndrome is traditionally, I have not seen for some time those patients, but while staying in India, I saw those patients when they are leaking, they whatever you give, that doesn't stay intravascularly, they leak everything. So I don't think even albumin will add anything over there, but that's something which should be studied, and it's a good research topic probably for the future.
If there is no question, can we move on to our next session?
okay, thank you, Ramesh,
Sir.
for your kind invitation. And as you have requested me, the subject I've kept the same, that post-operative fluid management in various surgical ICUs. So starting with this case 1, a 50-year-old male, BMI 26, no comorbid illness, is admitted with acute and chronic intestinal obstruction for 2 days. Patient undergoes emergency laparotomy, resection anastomosis performed. Duration of surgery is 3 hours. Intraoperative loss is around 600 ml. Intraoperatively, the patient receives 2 liters of crystalloids, 2 units of packed cells, packed RBCs, and is shifted to ICU on ventilator, the delayed recovery or blood loss, whatever will be the reason. After being shifted to the ICU, patient records a BP of 110/60, heart rate of 110, deeply sedated, saturation of 98%, and the last record shows that patient was draining urine at a rate of 100 ml per hour. So urine output was adequate. Now the patient has entered the ICU. So which fluid should use? Now let us recapitulate some of our basic knowledge so that the understanding becomes easier and we can relate it to the amount of fluid available in the various compartments. So suppose a patient is of 70 kg weight, assuming 60% of the body weight is water, so he has 42 liters. So 2/3 of that is within the intracellular fluid volume, that is around 28 liters. Another 14 liters is the extracellular. In extracellular, around 1/4 is in the plasma and around 3/4 is in the interstitial fluid. So that makes 3 liters and 10.5 liters respectively for plasma and interstitial fluid, and 0.5 ml comes to the transcellular fluid. All those fluids during secretions, suctions, etc. you get. Now, whenever you will have a fluid, in the good old days, people used to transfuse a lot of fluid to the patients after they used to come after surgery in the post-operative period, because more was considered to be the less. And it was believed that there is a space called third space where a lot of fluid escapes during surgery. And the more you administer fluids, the better it is for the patient, because it compensates for the fluid that has entered the third space. Now, this existence of the third space is today believed to be a creation of our imagination, because newer studies, they say that no such space exists, at least in the patient. But they also say that there exists something which is called functional extracellular volume, functional extracellular fluid volume, which is slightly different from extracellular fluid volume. Now, what is the difference? The difference is that these functional intracellular volume, they are not responsible for maintaining the balance between the intracellular and the extracellular fluid compartment. Now, how come? Because all this fluid which accumulates in the bowel lumen, in the ascites, in the peritoneal cavity, in the pleural cavity, so they all belong to this functional, this part of the extracellular fluid volume, but unfortunately they are not responsible for maintaining the balance between the intracellular and extracellular fluid volume. And over time, as we know that all of the vascular endothelium, the lining is protective layer is a double layer of glycocalyx, and which allows the molecules or the fluid to pass on from the intravascular to the extravascular compartment. So again, they accumulate in the extracellular fluid volume. But what accounts for that? It is because of the loss of integrity of the endothelium. So whenever we are administering fluid, we have to understand that how its distribution pattern would occur in relation to the composition of the different body fluids. And also, it is important to understand that in which compartment, which is the predominating cation and which is the predominating anion. Because the composition of the fluids, the varying composition of the biochemical fluids, would ensure that to what extent they're distributed into each of this compartment, because that is what is responsible for creating homeostasis, maintaining vascular integrity, and determining that whether fluid escapes from inside to outside on against the particular gradient. So in this connection, again, it is very important to know that, as you can see very clearly here, intracellular fluid, extracellular plasma, and interstitial fluid, they're all extracellular. In intracellular, the predominant cation is potassium. In plasma and interstitial fluid, the predominant cation is sodium. In intracellular fluid, the predominant anion is phosphate and the sulfate. The predominant in case of both plasma and interstitial fluid is bicarbonate. So the amount of bicarbonate that is present, if it is low, even if that solution is destined to reach the intracellular compartment, it will be probably inhibited because of the low bicarbonate. So it is very important to understand the composition of the fluid and the composition of the infused fluid, because their distribution pattern will be affected by a change in composition which occurs during or after surgery. If you look into this figure again, you can see that we have all the different fluids and their composition in terms of the different ions like sodium, potassium, calcium. They are variable, but more importantly, you see that their tonicity is also, some are hypotonic, some are hypertonic, some are isotonic in relation to the plasma. So now that is very important in terms of the distribution, because whenever we want to reduce the accumulation of fluid within the cells, we have to administer hypertonic. If we are giving hypotonic, that increases the cell swelling. Now you may ask that what is the reason of this theoretically, osmotically, and in vitro osmotic? There are a lot of particles which are or substances which may be osmotically active, but they will not be responsible for the osmotic gradient. For instance, the urea, because it can cross the glycocalyx. Therefore, although it is an osmotically active, it with this particle, this substance will not contribute to the creation of the osmotic gradient. Therefore, the theoretical osmolality will be different from in vivo osmolality. And that is the reason why a lot of times an apparently normal looking or a normal appearing fluid whose osmolality is likely to match the tonicity of the plasma does not match because of these inherent differences. So we have to answer that what happens to the fluid balance of the after surgery. Fluid loss happens in numerous ways. There is bleeding, there is drainage of ascites, there is urination, there is insensible water loss, and if we have to believe that there is existence of a third space, well, to include that, there is also third space loss. So this bowel, lumen, peritoneal cavities, pleural cavities are the example. And as I have said, that whatever fluid accumulates in the interstitial space combined with plasma gives something called functional volume, extracellular volume, which is our nearest matched parameter to the third space loss, which we don't know. And whenever we administer fluids, whenever there is overhydration with saline and surgical trauma, it leads to endothelial dysfunction. And whenever there is endothelial dysfunction, that protection provided by the glycocalyx is lost, and there is interstitial edema because of fluid shift from the intravascular to the extravascular compartment. So in these patients, when we treat with them with fluids, we have to understand the goals of our treatment and then start our treatment or guide our treatment. If a patient has a high risk, has a high risk, and the surgery is also high risk, it is always recommended that out of the two approaches, that is there are three approaches: the restrictive approach, the liberal approach, and the goal-directed approach. that the goal-directed approach should be recommended. So nobody knows what is restricted approach, nobody knows what is liberal approach, but less than 1 liter and more than 2 liters has been cited in many more studies to maintain the hemodynamic stability. So it is, but what is as restrictive and liberal respectively. But what has been seen is that whenever we adopt a restrictive strategy, probably there is less risk of pulmonary edema, etc., etc. But when we increase, there is liberal strategy, there is probably lesser incidence of post-operative nausea, vomiting, headache, etc. So there are advantages and disadvantages on both sides. But all said and done, goal-directed therapy has been found to have the advantages of both these therapies. And that is why it is recommended that goal-directed therapy by objective measurement of whatever it may be, measurement of the dynamic parameters, or if dynamic parameters are not measurable, or there is lack of infrastructure, the static parameters. So, but goal-directed therapy is probably considered. Only when the patient risk is low and the surgical risk is also low, one can aim to maintain a 1 to 2 liters of positive fluid balance without looking for goal-directed therapy. But in other cases, one should aim for a slightly positive fluid balance, but with goal-directed therapy, so that the risk of overload is minimum. So restore and maintain tissue fluid and electrolyte hemostasis and central euvolemia while avoiding salt and water access. This is our initial goal in all these patients. And the primary maintenance IV fluid should be an isotonic balanced crystalloid, and that can be maintained with any of those solutions which we consider as balanced if they're present with us. Now, why dextrose containing fluids are used? Now, important question. Whenever dextrose is metabolized, it releases water, and that water is distributed along the distribution of the water. So it is distributed across the total blood volume. So the glucose is metabolized, whatever remains is free water. 2/3 of it goes to the intracellular compartment, 1/3 comes to the extracellular. Out of that 1/3, 3/4 comes to the interstitial, 1/4 goes to the intravascular. So that follows. But whenever we administer normal saline, which has a high dose of sodium, so here it will not follow that pattern. So it will only stay in the extracellular compartment. So in the extracellular compartment, it will distribute it in that ratio, and ultimately it will cause this, it will be used as for the purpose of resuscitation. So what it reveals is that, so that in these patients where in the post-operative, IV fluids should be sodium poor and low volume enough, because this, when there is a phenomenon of redistribution, whatever fluids had actually escaped from the vascular gradually tries to return back, because the reducing inflammation, the capillary permeability is healing, restoring to normal. So till that time, the IV fluid maintenance should be sodium poor, because unless it is sodium poor, it will not reach the intracellular compartment. If it doesn't reach the intracellular compartment will be shrunken. It will not get any nutrition. So that is one, nutrition, perfusion, whatever. In patients who are edematous, hypovolemia, if present, must be treated, followed by gradual persistent negative sodium and water balance based on urine sodium concentration or excretion, or better is to go for serum sodium, no doubt. In high-risk patients undergoing major abdominal surgery, post-operative treatment with IV fluid and inotropes should be considered wherever we wish to target the tissue oxygen delivery, because fluids alone may not be enough to achieve tissue oxygenation. So in those cases, in high-risk patients with major abdominal surgery, the same should be considered. Those patients who fail to excrete their perioperative sodium load, especially whose urine sodium concentration is less when serum sodium is high, they should be reviewed and monitored for overload. So if there is overload, the fluid should be restricted. So in patients who are euvolemic and hemodynamically stable, they should return to oral fluid administration as soon as possible unless there are surgical contraindications. Next, coming to another case, case 2, 55-year-old male, diabetic, hypertensive, admitted with headache, followed by loss of consciousness for a day. CT head shows MC aneurysm bleed, undergoes craniotomy and clipping, external drain is inserted and shifted to the ICU. Post-operatively, patient is on elective mechanical ventilation. ICP is being monitored, GCS is being monitored. So which fluid should you use? Again, you have to remember that no doubt that crystalloid solutions are our choice. So there is no point in discussing non-crystalloid solutions. Normal saline 0.9% is widely used in neurosurgery because it is thought to reduce the risk of cerebral edema. Hypotonic solutions such as linger lactate, although linger lactate is considered as isotonic by many, but it is slightly hypotonic. They can also they should avoid it to minimize cerebral fluid accumulation, particularly when already the ICP is raised or the ICP was raised and it is slowly coming down. But we know that there is risk of this hyperchloremic metabolic acidosis, etc. So what should we do? So some people say that it should be an isotonic balanced solution. So isotonic balanced solution or normal saline, although there is no difference and there may not be any difference in outcome if one is able to regulate and if one can control, monitor the parameters, but certain things have come emanate is that a decrease in 1 milliosmol per liter in the plasma osmolality results in an increase of 19 millimeter mercury in the pressure of fluid movement across the blood-brain barrier, and a 3% decrease in plasma osmolarity results in cerebral edema with a 3% increase in the brain volume and 30% decrease in the intracranial blood CSF volume. So all these pose that one should be very careful in trying to ensure that the osmolality is not exceeded manifold. So therefore, it is important to avoid hypotonic solutions and also stick to isotonic solutions. Isotonic balanced solution is preferred over the normal saline in neurosurgical patients just for one reason, and that is the lower risk of metabolic acidosis and the lower risk of renal injury, which may be attributable to the high content of chloride. Now, then the question may arise, what are the causes of cerebral edema after fluid administration? Well, fluid is one of the causes. So besides fluid administration, also fluid is an important cause which may contribute to cerebral edema after neurosurgery. But it occurs usually due to a combination of causes on account of endothelial cell damage, tight junction disruption, abnormal transcellular transport. They can be partitioned into three categories: vasogenic, cytotoxic, and interstitial. Out of them, vasogenic cerebral edema is the most common type of brain edema, which originates because of the increased permeability of the capillary cells. And 1% increase in the brain water content is equivalent to 4.3% increase in the brain tissue volume. And again, brain water content surrounding the resection site increases by 3% or more during the first 72 hours following surgery and resolves within a week of surgery. Now, don't take all these numerical values as gospel truth. It is like, I tell you, if we buy a new car and the car is supposed to give a mileage of say 20 kilometers per hour, it often may not give 20, it may give 15, depending upon how many buffaloes are there on the road, how many cows are there on the road, how many speed breakers are there on the road. So, but this gives us some indication that as to how the variation in the water content, how steadily that you can see if you look into these figures, it becomes a parabola. So their importance can be to understand. Now, what should be done if the patient develops diabetes insipidus? This is a very common condition in our patient. Many times it is diabetes insipidus, many times it is cerebral salt wasting, whatever it is. We know that it is common after head injury, pituitary hypothalamic lesions where the patients have polyuria, dehydration, and hypernatremia. So in those cases, patient should receive maintenance fluids plus 3/4 of previous hour's urine output every hour, or previous hour's urine output minus 50 ml, whichever is convenient. So these have been found to be useful in a large sets. So they can be considered. I'm not saying again that this is the one single formula. And the fluids administered should have a low sodium load as half strength normal saline and D5W when the urine output is more than 300 ml per hour. At least for 2 hours, one can start with vasopressin at 5 to 10 units. We know that it can be given intramuscular or subcutaneous, or alternatively, desmopressin 0.5 to 2 mg 8 hourly or by nasal inhalation we can administer. Let's move on to the third case. 25-year-old female, multigravida, 32nd weeks of pregnancy, presents with seizures and hypertension for a day. Patient has swelling of ankle, which is going on since early pregnancy. And after stabilization, pregnancy is terminated. And by laparotomy, post-operative patient is shifted to for elective ventilation. Heart rate is 120, blood pressure is 170 by 100. Urine output is 20 to 30 ml per hour. Patient is sedated. Magnesium levels are within normal range, no active bleeding. We have given antihypertensive with L-DOPA, and labetalol has been administered. So which fluid should you use? Whenever these patients come, our main concern is that they may go into pulmonary edema. So we should know what causes the eclampsia patients from going into pulmonary edema. Either increase in the preload, like excessive fluid administration, resolving peripheral edema, cardiac causes, myopathic ventricle, diastolic dysfunction, valvular heart disease, if there is any. In ours, we get a lot of patients with valvular heart disease who are not diagnosed in their initial childhood or growing age. They are diagnosed during pregnancy. Increased afterload, and sometimes it may be a combination of all of the above. So monitoring the administration of IV fluid in eclampsia is very important. Maintenance therapy is commonly given slowly over 24 hours, and it may be calculated to match the urine output plus the insensible loss. So we have to go slow. And you have to remember that the clinical markers of euvolemia may be inaccurate in patients with eclampsia. Oliguria may develop because of intrinsic renal disease, including ATN, and it may not respond to plasma volume expansion with an increase in urinary output. Again, the use of CVP monitoring, although it is done, but it may be dangerous at times because bolus doses of fluid may lead to sharp increase in the wedge pressure. That is, the pulmonary pressure may rise even before rise in CVP is observed. So that is another risk. So all women who receive IV fluids more than maintenance doses should also be monitored using pulse oximetry, because that will be easily able to detect the earliest occurrence of pulmonary edema. A very simple suggestion, but it works. Now, what to do if patient becomes oliguric? Now, there can be two situations. Either the patient may become oliguric with a positive fluid balance, or patient may become oliguric with a negative fluid balance. So give 300 ml of isotonic fluid challenge, no response, restrict fluids to match losses. If continuing oliguria, start vasopressors, then consider invasive hemodynamic monitoring. You have no other option. If the patient is oliguric with negative fluid balance, then again, after giving 300 ml of isotonic fluid challenge, repeat it every 30 minutes until a positive fluid balance or adequate urine output comes. If still persistent uriguria, then you have to restrict fluids, and you start vasopressors, and also consider invasive hemodynamic monitoring. So what are the differences in fluid resuscitation between eclamptic patient versus any other normal hypovolemic patient? Now, the focus of resuscitation should be on restoring SBP to more than 90 in cases of this eclamptic patient, with less attention paid to urine output and HR as guide to the establishment of euvolemia. And initial resuscitation of clear fluids should be superseded by blood component therapy, because in these patients there is in these patients the blood component therapy is often missed until the patient goes into DIC. The possibility of overtransfusion and pulmonary edema should be considered once the systolic blood pressure has stabilized, and any further fluid therapy should be based upon replacement of losses or guided by invasive monitoring or appropriate hemodynamic monitoring, as I said. The rapid and adequate restoration of renal perfusion may be the only opportunity to prevent subsequent kidney injury. These patients are more prone to kidney injury because they already have some kidney dysfunction before. So if we combine all the different scenarios and try to somehow, it is not possible to exactly match everything like match the following. But in surgical patients, balanced crystalloids, if AKI risk or IV fluid volume more than 2 liters, lactated ringer solution we can use. We can use plasmalite if we are available, although long-term outcome makes no difference. In sepsis, we use balanced crystalloids. For traumatic brain injury, normal saline. And for special cases like patients with diabetes and DK, renal dysfunction, abnormal electrolytes, abnormal acid-base balance, we have to individualize the patient based upon the changes in their ions and the state, as I mentioned before, administering the fluids. So my take-home message would be that management of post-operative fluid should be done considering both patient's unique status and intraoperative events. Tendency towards empirical fluid management can be replaced by evidence-based strategies. Goal-directed supplementation is the most rational approach to assess the patient and maintain optimum fluid balance. The debate around colloids and crystalloids should also be considered, though it is not likely to end as of immediate near. And advantages of disadvantages of each solution must be evaluated according to the specific condition that is present in the patient. Thank you very much. I hope I have not exceeded too much of time. Thank you.
Thank you, sir. With the cases and how to manage those cases you have presented, it was very nice. We have few questions to take. First one is if there is no hyperchloremia, then still NS normal saline to be avoided or not?
Yeah, the normal saline causes two things. One, it this chloremic metabolic acidosis and also leads to the increased risk of kidney injury. So, but that risk happens when you infuse too much of normal saline. It doesn't happen with a normal 1 liter, 2 liter of normal saline that we routinely administer. So if the patient is at a risk of renal injury, or if too much normal saline has been pushed in a patient whose other this organ dysfunction was already there, or the patient was having abnormalities, it is then that one has to be careful. So unless we give in very excessive amounts, the normal saline is safe.
In extension to that, for how many days post-surgery we should use IVC assessment plus lung ultrasound or clinical signs of dehydration? And when should we use formula of urine output plus 500 ml?
This will vary from the patient. I told two conditions. One is the patient risk and the surgery risk. Both can be low, both can be high, either can be low and either can be high. So this will vary on an average. If you ask me that if a patient is having a major surgery and patient was not at a very high risk, and 2 to 3 days one needs to monitor the fluid balance meticulously, because once the patient starts taking orally or through the Ryle's tube, there are chances of fluid or either hypervolemia or hypovolemia becomes less. It is only till the time patient is purely on IV fluids, and then the IV fluids gradually come down and the enteral fluid takes precedence. So during that transition, it is good to see the measure those IVC and etc. And lung edema, the pulmonary edema is when you give too much of IV fluid. One needs to check that. And particularly if the patient it is an emergency surgery, sick patient, pre-existing diseases, cardiac functions not so good in those cases.
So, in general, like which is the fluid of choice for post-operative patients, sir? Like some intestinal surgeries, DFNS or plasma-light solutions or normal saline.
Solutions may be the choice in other places, but in our place, it is either DNS, that is half strength, or full strength with dextrose, or with normal saline.
So how will you calculate third space loss, sir, based on the patient's like which surgery based on the surgery majority like
There are formulas given, you can see them, but I think nobody can calculate third space loss by any formula. It all depends upon how the surgeon and during surgery it is all based on rough estimates, and you need an overall picture to gauge that estimate.
yeah. Any fluid of choice in renal transplant patients and liver transplant patients, sir?
So as you have already mentioned during the time of albumin, that whenever there is risk of kidney injury is high, whether it is hepatorenal syndrome or whether it is kidney, you avoid high chloride containing fluid. You try to give isotonic, avoid starches. Starches, of course, you don't use when ICU is considered. So in all those cases, I think it is good to stick to a balanced salt solution.
So regarding cumulative fluid balance, what is the role of cumulative fluid balance? Because it varies in case to case, sir. In case of trauma, in the first few days, the cumulative fluid balance will be very much positive because the loss also will be there. And same thing in the pancreatitis patient also, they will be in severe hypovolemia. But in other cases also, cumulative fluid balance after 7 days will be calculating. Now, how to place that, how to clinically use
That
that?
is the magic thing, is that whenever we talk of cumulative fluid balance, even if the cumulative fluid balance is high, the patient may be in hypovolemic because of the fact that the vascular compartment may be still dry. It may be empty. All that fluid which is accumulated into the different places in the pleural cavity, peritoneal fluidity, bowel, lumen, actually, they are not responsible for maintaining the balance between intracellular and extracellular compartment. So you will have to squeeze out that fluid. And if you administer diuretics will draw fluid from both compartments. It will take out. So it is very important that you monitor the fluid movement properly. Look into the lactate. See that the patient is hypovolemic. See the little bit of your IVC and pulmonary edema. And as has been mentioned, that diuretic albumin combination, it was just touched upon by Dr. Prashanth. So this is something which may be useful, because after all, albumin is the mainstay. The vascular oncotic pressure is maintained, so it may reduce but all said and done, it will only get mitigated once fluid stops receding from the vascular to the extravascular compartment.
Professor, any comment on the cumulative fluid balance?
I think is nicely stated. I wouldn't bother too much if cumulative fluid balance calculated is positive. I would look, but we need it to define fluid accumulation syndrome because it's the best we have, either in conjunction with daily body weight. But if the patient is thriving, is doing fine, I wouldn't bother too much. But if there is a positive fluid balance with end organ dysfunction, like B-lines was mentioned, or AKI, or intra-abdominal hypertension because of ileus and bowel distension, or an increased lung water, then it's another situation. And I think it's the best we have to diagnose fluid accumulation syndrome. But yet,
there are only two things you can do, Ramesh. One is to limit the intake, and number two, go for dialysis. There is no third choice. So if you think that the patient is going towards organ dysfunction, because of fluid accumulation, and you have already restricted intake, the only option is left, even if you're ultrafiltrate of 500 ml or 1 liter, may just reverse the process. I'm saying just from practical aspects. If it is so that the organ dysfunction is not the something to bother about, and there is still you can restrict further, we can restrict further. As I told, diuretics will draw out fluid from all the compartments. So if this patient who is already hypovolemic, the vascular compartment is already dry, it will squeeze out so more, it will become more dry. So those are some of the considerations we will have to take on an individual basis from patient to patient and at the stage of their. I think Dr. Manu Malbrain may elaborate on that.
Well, you say restriction, but the problem is that all the big trials looking at restrictive versus liberal or standard, whatever you name it, didn't show any difference on the hard endpoints like mortality or impact on organ function. In fact, restrictive fluids carries a higher risk for AKI usually. But you're right that everything, well, if we assume fluid accumulation is iatrogenic, partly, or it could be poor medicine, that you didn't do the right intervention, the good source control, the proper antibiotics and so forth, then fluid accumulation is a biomarker for critical illness. And the sicker you are, the more fluids will be leaking. But prevention is key. And in the discussion on saline versus balanced, I would not call it normal saline because there is nothing normal about it. So if we can avoid it, and if we can avoid a positive sodium balance, we will probably also avoid a positive fluid balance. So avoiding fluid creep is key, because most of the fluids we give, it's not for resuscitation, but it's for maintenance, it's nutrition, and it's to dissolve other drugs in like antibiotics and painkillers. So usually patients will not need maintenance except for the case a long surgery and there is nil per mouth that you may want to cover if it goes beyond 6 hours, let's say. But otherwise it's probably not needed. So prevention first. Of course, restriction, I think albumin 20%, as Prashanth mentioned, may also have a place, because even if it's not 1/5, volume-wise, it's 1/1.4, so at least it's less volume. Limit the sodium, limit the chloride, and then if there is an impact on organ function, as you say, you remove it. You start with diuretics. Furosemide stress test could be interesting to see if the patient is ready, and then either in combination with albumin and CVVH. But prevention is key, and restriction and limiting fluid creep is the first step.
So another question is, in post-operative patient, how much percentage of oral fluid and how much percentage of intravenous fluid should be balanced between those two? That's what is the question. I think if the patient is taking orally, I think maintenance should be done by orally.
Traditionally, see, how do we start? We start EBN 2 scoops in 100 ml and 3 hourly or 4 hourly. That's if the patient tolerates. Then we gradually increase, and then we gradually come down on the IV fluids. Suppose your IV fluid, I'm going right away to the prescription, because if we discuss theory, we will be discussing the same theory again and again. So the basic remains the same, as Professor has said, that we have to restrict and we don't have to give any unnecessary fluid so that fluid creep is avoided. So when we start, as the moment patient becomes, we feel that there is no reason not to start fluid, we start enteral feed. So the moment we start enteral feed, say 2 scoops in 100 ml water at 3 hourly. So the immediate you gradually start reducing your IV fluids. So what was going at 100 ml per hour becomes 50. So ultimately you balance based upon the total output and the total volumic status of the patient. So then as you increase from 2 to 4, you further reduce. So finally, you are probably left with 20 ml of whatever fluid you are administering per hour, just to make it 20 into 24, 481 pint. And finally, when the patient's over a period of 4 to 5 days, if patient tolerates, you stop totally IV. Except, of course, the IV goes for correction of magnesium, potassium, all those, that's different.
Good. So another question is there any time limit for leakiness in sepsis? Like when the sepsis capillary leak will stop? That's what is the question.
Nobody can say, because nobody has seen any leak. So it is only we have been able to realize that there is a leak. That is the reason. But it is when it starts, when it stops, how it behaves, what prevents it. These questions I think they're far ahead from answering. We have Professor Manu Malbrain may have highlight some of this, that how leakiness.
Well, burn patients are a very good patient population, because there you know when is the culprit insult, when will be the capillary leak. And there is some data looking at urine, albumin over creatinine ratio. And typically you see it increasing within the first 3-4 hours and then decreasing. So it could be that you have this kind of capillary leak that increases, decreases. That was also the reason why in burn patients, initially we were afraid to give colloids because of the leak, and only start the colloids after 6 to 8 hours. In septic patients, we looked at the CRP divided by the albumin. So if you have a high CRP, is a lot of inflammation, a low albumin, it's leaking. And this ratio you see typically going up to day 3 and then kind of normalizing. So one could say that capillary leak is transient if you do the proper thing. If your source control is correct, your surgery is correct, if there is no abscess collection, antibiotics are right, and so forth. So it's a temporary thing, but on the other hand, it can occur very fast and it can occur remotely. So if you have an insult in the peritoneum, you can have a leak in the lungs. And this will be individual for each patient. Some patients will develop pulmonary edema, while others will develop abdominal hypertension as a consequence of a global increased permeability syndrome. So I agree, there is no one size that fits all. It's personal, it's individualized. But these parameters, like looking at CRP over albumin, urine, albumin over creatinine ratio, could be helpful. So I think monitoring and a multimodal monitoring, so not only fluid balance, body weight, bioelectrical impedance analysis, maybe ultrasound, VEXUS score in combination with cardiac output and transpulmonary thermodilution, lung water, if available. But maybe just clinical signs like pitting edema, the Goddess sign, could be helpful as well. Capillary refill time to look at perfusion. So I think it's a combination, multimodal.
Another question, sir. How do I deal with post-operative patient who is in deresuscitation phase, already positive by 4 liters, and his chloride is around 115, but still in fluid responsive? Which monitoring should I use, and which fluid is preferred?
I think Professor
Chloride is around 115. Same thing is like in the deresuscitation phase with a positive balance of 4 liter.
Yeah, is a difficult patient. Is a patient that is fluid accumulated. Probably the sodium may be high, the chloride is high. It all depends on the impact of the accumulated fluids on end organ function. And you always have to deal and treat the organ that is carrying the highest risk for killing your patient. If that patient has a PF ratio of 60, is on 100% of oxygen, it's a different thing than if the patient is breathing spontaneously with no supplemental oxygen. So again, look at the patient don't treat just the numbers, and it depends. But the tricky ones are the ones where you have a therapeutic conflict, where you have a problem with the lungs, but also with the blood pressure and with the kidneys, and you have to choose. If I give fluids, it's good for the kidneys, maybe bad for the lungs. So it's this that you have to put in balance, and it's dynamic. So on day one, it could be that patient may need fluid removal, but on day two, we need to support the kidneys. I hope this answers a little bit, and there is no one single answer to solve this. For the monitoring, if you ask me what monitoring should I use, so next to the clinical parameters, fluid balance, body weight, cumulatively, we use bioelectrical impedance analysis, looking at the extracellular, intracellular ratio. So normally the fluid is intracellular and the ratio is below 1. If the ratio increases, it's a kind of indicator of capillary leak. This will also give you the volume excess, which is a kind of a surrogate for cumulative fluid balance. And in our ICU, we have the advantage to monitor lung water, extravascular lung water, and the pulmonary vascular permeability index. Of course, in combination with ultrasound, cardiac ultrasound, full body ultrasound, VEXUS. And the lung water, I think, is a very good parameter to guide deresuscitation. And the studies that Prashanth mentioned by Greg Martin, looking at albumin and diuretics, nicely show that by removing the fluids, you may improve PF ratio and decrease extravascular lung water.
We also monitor, we have the hemisphere that
Hemisphere.
yeah. So
and with the EV1000, so the
in 1000 they have actually taken back. So
Yeah, it's not
they have
available.
introduced hemisphere as usual, though the EV1000 has become old. So this hemisphere is the new version. So that
very expensive.
expensive. In India, it costs 50 lakhs.
Yeah. But I think they will relaunch again transpulmonary thermodilution from Edwards, which now became BD. I think BD is now the company that took over Edwards. But a calibrated technique is my favorite in patients who are unstable. So whenever you do something on preload, afterload contractility, so when you're giving or removing fluids, inotropes or vasopressors, I think you should have a calibrated cardiac output monitoring technique, either the Edwards or the Pico or a Swan Ganz. If there is RV failure, I think is still a very good monitoring tool, albeit a bit complicated and used very often.
And whenever in doubt, I find that probably with going for renal replacement and taking out is probably always beneficial than waiting and trying to see what happens next. Because
Fully agree, even if kidney function is still normal, but you have an issue of fluid accumulation and lung water capillary leak. And the advantage is that you have full metabolic control. So your electrolytes will be fine and there is no issue of hyperchloremia or sodium. And that's the real advantage, because you make place for buffers to have homeostasis metabolic.
There is no other question. Okay. Okay, sir. I think with this we have come to the end of this session. Last question is, if IVC is dry and fluid accumulation in the peripheries, should we go for renal replacement therapy?
Oh, if you believe the VEXUS score, if IVC is small, you stop because there is no venous congestion. Only afterwards you move to the portal, hepatic and renal veins. So I'm worrying if IVC is really dry, where would be the fluid accumulation? Again, if it's high lung water, PF ratio of 60, 100% oxygen, then renal replacement therapy as we suggested. If the albumin level is low, there may be some place for hypertonic albumin. Try to mobilize the interstitial fluids to the intravascular space. And this was shown by Robert Hahn in some pharmacokinetic studies, that there is in fact a shift from the interstitium to the intravascular. Which, if you believe the revised Starling equation, you will not believe that this is happening, and because there is only filtration, no reabsorption, and it's the lymphatics that bring the fluid back. But at the end of the day, it works.
Many intensivists are fond of albumin in many cases, actually, in this type.
I'm not, because I agree, it may be the drug that is very expensive and misused for a lot of wrong indications, like intradialytic blood pressure,
Hypotension, yeah.
priming of ECMO, or yeah. But in selected cases, again, individualized, it's not to treat the numbers, it's not for the aesthetics of the albumin levels, it's to treat the patient.
Yeah. Thank you, sir. With this, we have come to the end of this session. Thank you, Manu sir. Thank you, ANIRBAN sir.
Thank you very much.
Sir.
Enjoyed the
It was an
discussion.
excellent discussion.
Learned a lot of new things. Thank you.
Pleasure. Thanks, Ramesh.
Thank you, sir.
Thank you.
Bye-bye.
Good night.